Thanks, Walt. So I suspect that my target audience is mostly the folks out in the internet world this morning. I'm going to talk a little bit about navigating UK's trauma system, although a lot of this is applicable to any tertiary care or level 1 trauma center. I suspect most of the folks that we're talking to out there in the world this morning, it will be mostly applicable to bringing folks into UK, although if you do at times transport as far over as one of the other trauma centers, then that's certainly a lot of it will be things you can use there as well. Just objective this morning, kind of what we're going to cover briefly. We'll talk about sort of pre-hospital strategies or things that you can do to help yourself and help us before you even get here to us. We'll talk some about what constitutes a trauma activation per our protocols here. These are things that do change from time to time. We're still, to my knowledge, the last one that I've seen produced was kind of in the fall of last year, and we'll sort of cover what exactly that constitutes, because it's not something that we do a great job of sort of advertising to you guys, the folks that are bringing these people in. And I know sometimes it leads to some confusion because nobody really knew this patient was going to be a trauma or not. We'll talk about who are all these people that you see when you bring in patients. There's 10 million people at bedside, sort of who are all those folks. And then we'll talk about best practices as far as how can we communicate you to us, us to you in a most effective manner to be able to make sure we get all the information transmitted across and that everybody leaves without hurt feelings, that sort of thing. This was for my trauma month this past year, kind of a real world sort of demonstration that any extra heads up that you're able to give us is helpful. This was a patient that was a local Lexfire patient. I was across the hospital, as was the rest of the trauma team, and that's not really a page that you want to see when you're 10 minutes pretty swift jog across the hospital. Walt says to keep this at least kind of a PG or so rating, because we're not sure who all's out there in the world, but I think everybody knows kind of how this top part ends. Prior planning prevents you know what. So the amount of prep time that we have can make a difference. Obviously, there's going to be times when, there's a Lexington patient, they're going to be local and not have much time to give us a call. Or if you're coming from one of the surrounding counties and fairly close by, you may be kind of up to here and taking care of the patient and not have a ton of time to give a shout. But any information that you can give, you're bringing somebody in that doesn't have good right-sided breath sound, something like that, we take that to heart. Those are things that we can make sure we have a chest tube set up. Or you tell me that their GCS is declining and that gets relayed to us, I'm going to have that airway box cracked open and have a tube ready if you guys haven't already done it yourselves. So anything that you can tell us and any sort of lead time that you can give us, we can kind of have those things set up and available to help take care of those patients as soon as you hit the door. I guess probably most people in this crowd know who that is. I guess it's kind of dwindling. Not many people have seen that show anymore. I suspect there's a few that have. So what happens when you call in, whether it's radio or phone? So up at the top, the trauma report is you. It comes in to here at UK, at least, our centralized dispatch. And I'll say it's a system that, based on the amount of volume that we have coming in, we kind of have to do it this way. But it sort of ends up being one of those things. It's almost like the telephone game. Sometimes things get told to dispatch, and then it has to get reprocessed, relayed to the charge nurse. It's not a perfect system. Sometimes we do lose a little bit of information, although I feel like the vast majority of the times they do an excellent job with the volume that they have being able to relay all that information to us. But one of the things that is hard to overcome is that there is a little bit of a lag time between them being able to sort of process that information and get it to the charge nurse. It's not a lot of time, but like we were just talking about, any extra time that you can give, just understand that for them to be able to relay it to the charge nurse and then the charge nurse being able to relay it to us, there is a little bit of a lag time. So sometimes, especially if it's a local scene, we don't have a lot of time to get things pulled out. Now, just as with you guys being out in the field, kind of the same thing here, that at times you just sort of have to roll with it. We're all doing the best we can, so we'll certainly make it work. So what happens when it gets to the charge nurse? There's a decision that's made kind of between dispatch and the charge nurse as to, based off the information that you give, sort of what acuity is this going to be assigned. If you think about it in sort of three different boxes, they're the ones there at the bottom. For the ease of simplicity, we'll kind of say everything that's not a trauma alert or a trauma alert red, we'll just kind of call non-alerted traffic. Those would be sort of the run-of-the-mill traumas that, you know, coming in with just like a broken wrist, that kind of thing, low mechanism MVC, things that don't need to be seen immediately. Those are the ones that you bring in, you're met by the nurse, they take report, they'll triage them from there, and then we'll see them. Next in line would be trauma alerts. We'll talk a little bit more about what the criteria are here in just a minute, but those are the things that are sick, they need to be seen immediately, but they don't demand the full resources of the trauma center. In other words, having an OR on standby, having the whole trauma team down there, having anesthesia down there. But with trauma alerts, you do get us, that is one of the residents, one of the ER attendings, and we'll talk a little bit more about who else is there here in just a minute. Depending on where you're at, I know back home we just kind of call them level 1 traumas. Our nomenclature here is trauma alert reds. Those are the sickest patients, the ones that immediately need to have full resources available. So who exactly comes up with all this criteria? Sometimes we kind of wonder about some of the things that are produced, but there's actually, it's made up by trauma attendings, ER attendings, hospital administration. I don't know exactly, well, I don't know how often they review this, yearly or more often than that.
Kind of when anybody says.
When somebody has a problem. So these things are reviewed periodically. Like I said, I think we're operating still most recently off of what was produced back kind of in the fall of last year. It's always a little bit of a battle of what we call sensitivity versus specificity. Without getting off into the weeds of kind of all the stats and all that stuff, basically the principle is sensitivity is, if you think about it, if something is very sensitive, it's sort of a very fine filter that's going to catch lots of things. Specificity would then be going through and saying, does this meet criteria, does this meet criteria? Sort of a real world example as far as sensitivity, they recently added during this most recent revision that trauma patients that are on blood thinners are going to be a trauma alert. So that's a high sensitivity category. You get all these meemaws, I say meemaw falls that are on Coumadin that automatically become a trauma alert. It's a lot of them. And at times it is kind of frustrating, but the goal there is to have a high sensitivity. That's a high risk patient, right? You've got, you know, Meemaw's old, you know, if she falls even not on blood thinners, she's kind of a higher risk patient anyway, but by the time you throw on blood thinners, it's a higher risk. Now, are all those going to have head bleeds or significant injuries? No, we understand that, but they want to have a high sensitivity that, in other words, when that high risk patient rolls in, we're going to see all of those. We're going to catch all of those in the filter and have them be seen immediately. Versus specificity would be if, you know, after that, you're sort of going through and having other criteria to kind of, you know, weed those patients out. Maybe after that, you're going to go off of, you know, GCS or something like that to determine how sick these patients are. With specificity, you're narrowing down your group into sort of a more narrow criteria. The risk with having a higher specificity is that you're going to miss some of those sick people. So it's always sort of a battle that you don't want to have something that's, you know, 100% this or 100% that, depending on what you're trying to do. So we can always cancel these. You guys have probably seen these from time to time when you bring them in, especially these Meemaw falls. You know, they roll in, they're like, waving at you on the stretcher. They look great, GCS 15, and we're like, yeah, you get the initial vitals, and it's like, this doesn't need to be an alert. We can go ahead and cancel it. From the standpoint of money, you know, that's something that is not our primary concern, although we all have to be, you know, good stewards of the resources that we have. We'll talk more in just a minute, but anybody that comes in as a trauma alert automatically ties up a CT scanner. It gets held for them, so that way they can go directly there. It also is a pretty significant monetary type thing that on the tune of several $1,000s to literally like waltz in the door as a trauma alert, you automatically have several grand tacked onto your bill. Now, if we cancel those as they come in within the first few minutes, kind of that primary, secondary assessment, they don't get charged that. So if it's not necessary for multiple point of views, that's why we do try and cancel them. And we'd rather do that than upgrade them. We can upgrade them. It's not a big deal. All we have to do is tell the charge nurse, hey, this person's sick. we're going to upgrade them. Most of the time it's that they've already come in as a trauma alert and we're going to upgrade them to a trauma alert red. The problem with that is when you're upgrading, it has to get paged out. There's a little bit of a lag there. And then like we were talking a minute ago, the trauma team may be on the other side of the hospital. And if the patient's already there, you can have a pretty significant amount of lag time between when they're able to actually come down and evaluate. So we'd much rather cancel than upgrade. So we'll talk about those non-alerted patients. We've already sort of run through this briefly. These are the ones that are not sick or not as sick that you're going to kind of give handoff to the nurse. They'll triage them. If they feel like they're sick enough to be seen immediately, they'll come find one of us. Otherwise, they get kind of put into the general basket. Here at UK, at this point, we don't have a pod system that some places operate with. In other words, all of the residents see all of the patients, all the attendings see all the patients, with the exception of peds. So the same guys that are seeing all of trauma are seeing all of those back hallways and everything else too. And like everywhere, we're chronically kind of understaffed. So they get sort of put into the main hopper, if you will, and get fed through with all the other patients. So we see them, and then if we need to consult trauma, we can do that. If we need to consult orthopedics, whoever, we can get them to come see them subsequently. So this is a very busy slide. The next few will be kind of busy, but I felt like this was important information, that this is directly from the protocol that I wanted you guys to be able to see, and we'll kind of run through them briefly. It's one of the gripes that I've heard several times. I don't know with you guys, if it's a frustration. Obviously, we've got a couple of UK guys here too that know these, but I'm often told, we didn't know that this was going to be an alert. We would have done this or that, or taken this a little bit more seriously, had things kind of tidied up a little bit more if we had known that it was. So this is what the trauma alert criteria is. These are the patients that are in that middle tier that are not quite sick enough to meet that trauma alert red criteria. So any intubated trauma patient automatically is an alert. Now, if they're intubated by you guys out in the field, that makes them a trauma alert red. If they're intubated at the outside hospital, it makes them a trauma alert, unless they have ongoing respiratory difficulties. So that's, depending on where they're intubated, kind of makes a difference for us. Anybody that's a respiratory rate less than 10, greater than 30, that buys you an alert. GCS less than 12. Penetrating head trauma, and these aren't perfect, We had somebody back, it's been a few months ago, but they were like GCS of 13 or so. They were shot in the head. They were coming in locally. So immediately you're kind of like, gosh, but then as they're describing, it's like their vitals are stable, they're talking, sounds okay, they're an alert, but doesn't sound that bad. And they rolled in, and they literally had been nailed like right between the eyes. And as we take off the bandage, it's like, well, this isn't like a, like a skin, like flesh wound kind of thing. This guy got drilled between the eyes, and on the CT scan, you could see the bullet had actually gone in and lodged back up kind of in this part of his skull. It had just sort of like sheared through his frontal lobe. So it's like, okay, let's upgrade that. We upgraded obviously before the CT scan as soon as we saw they had gotten drilled between the eyes, but it's not perfect. That's a patient that you say gets shot in the face and has a bullet lodged in their brain. You're like, well, yeah, that needs the trauma team. That needs the whole thing. But according to our criteria, it's a trauma alert. It's not perfect, but penetrating head trauma covers lots of things. It may be, they have, a stick stuck in their scalp or something. It's impossible to do, every single circumstance. You wouldn't want to anyway. You have the charge nurse flipping through like a 500-page binder, like where exactly does this fall? So these are guidelines, just kind of like, SOGs or whatever your department has. They want to allow some freedom there and try and not, drill down too far to where it gets confusing. Establish the neck, chest, back, abdomen, or pelvis. Again, this is a wide array. And, there's at the bottom, you'll see it lists emergency medicine attending discretion. It's not uncommon that the charge nurse will come in and say, hey, this is a stab wound that would probably be a trauma alert, but EMS said this guy doesn't look good. We think it's pretty deep. And based off of what you guys are saying, we may go ahead and say, skip the alert, go ahead and make it a red. Known spinal cord injury, this used to be, they actually changed this during the last revision. Before was suspected spinal cord injury. And I mean, as you guys know, sometimes you get these folks that are, for lack of better terms, turds that are kind of trying to play things up some, and maybe they're not moving their legs because it hurts a lot. And it kind of, you guys are sort of reporting the information that you have, and it led to a lot of these patients that ended up being alerts that didn't truly have any spinal cord injury. They were just kind of being turds, not wanting to move things. So now it's known spinal cord injury. If they come from an outside hospital and have CT to suggest that, fine, we'll alert them. Or if it seems like once they, get here that we're truly able to kind of tease that out, get their pain under better control, and, they have a spinal cord injury, then maybe, or it seems pretty likely we can kind of go from there. But that is one they changed because the sensitivity was catching too many patients that weren't legit. Any pregnant trauma patient greater than 24 weeks. This is another one that's a high sensitivity that we've had patients that get called out as a trauma alert that literally stroll on from triage, like they walked in and they stroll on back to the trauma bay, like ambulating on their own. It's the reason we do that is you can have, a colt injury to baby that mom looks pretty good and all that force got transmitted into baby. So that's to be able to get the OB team down, do extended fetal monitoring, things that we don't even have the ability to, do with the equipment we have. We have to bring in outside folks. So that's to be able to kind of mobilize that team a little bit more quickly. Age greater than 65, significant chest, abdomen, pelvic, or extremity injuries. That's just because old folks, are injured more easily. We kind of try and increase the sensitivity with those guys. Known anticoagulant use. That's why they ask you on the radio. Dispatch will say, are they on Coumadin or anything like that? They're trying to tease that out because it becomes a trauma alert if they are. And that's something that, as you guys know, who knows a lot of them, even if they are awake, half the time they can't even tell you what they're on anyway. So that's something that we can tease out. But if you're able to get that information from the patient or family, it can be helpful. 2 or more proximal extremity fractures, open fractures, or any pelvic fractures. So just suggesting that they're pretty banged up. Amputations above the ankle or wrist get you a trauma alert. All intubated burn patients. And then anybody that's greater than 20% body surface area, 2nd or 3rd degree burns buys a trauma alert. Suspected inhalational injuries. So if these people have been in a house fire, if you have co-oximetry, or if they come from an outside hospital with a CO2 level or CO level, or if they have singed facial or nasal hairs, then that buys it. Because of that concern for airway compromise, it could evolve. If they get shock greater than 220 amps, that buys it. And then, as we already talked, there is some discretion in there. So as far as resources, this full list also applies to the Trauma Alert Red. The Trauma Alert Red just buys you some extra people. So as we already talked, you get me, you get Walt, you get the trauma surgery chief resident. A lot of times they don't hang out. They'll kind of be down there and sort of look at the patient. They'll eyeball them as they roll in the door and just sort of say, looks good. That's something that changed within the past year or so. Formerly, they didn't actually come down, but the American College of Surgeons has kind of revised their recommendation. They say, even on these patients that aren't as sick, a trauma surgeon needs to at least kind of eyeball them as they roll in the door within the first few minutes. OB, that's just if applicable. Obviously, we're not calling them on everybody. You get nurses, techs, or fine paramedics, all at bedside. And those folks, you'll get some extra folks sometimes with the Reds, but usually that staff of guys and gals is more or less the same between the two. So radiology, when you come in as an alert, that actually brings over the x-ray machine. You'll see them out there in the hallway waiting. And it also holds a CT scanner, which sounds like not that big of a deal, but the hospital looks at it as a pretty significant impact as far as throughput. And again, from a financial standpoint, we've got 2 CT scanners, for those who haven't seen them or don't know, that are kind of directly adjacent to the trauma bays through that sort of little hallway that goes between the 2 charting areas. So we can get them over there pretty quickly, but that holds that scanner for the duration of that alert until we release it. So you're potentially bringing it down to 1 scanner to move all of the rest of the ER through, and occasionally patients from upstairs too. So that can be a pretty significant impact. So we try and figure out really quickly if that's something that we need. Respiratory will be kind of around on these trauma alerts. Obviously, if there's somebody that's intubated or sounds like an airway issue, then they'll be hanging out, but they don't play as big of a role in general with the alerts. Talked about CT. The blood bank refrigerator is a little squatty fridge between the 2 trauma bays. You've probably seen out there. We have uncross-matched blood that is available there. The supply tech, if you haven't ever seen these guys, we have one in the department most of the time. They help grab things during these traumas for us, and also otherwise, like not during traumas. Pharmacists, we're about to have those here 24 hours a day. Right now, we still intermittently have them at night. Otherwise, during the day, they're here all the time. They do an awesome job helping us out. than the chaplain, which sounds kind of morbid, particularly if they're not like a real sick patient, like, kind of come in and like cast some holy water on them. But they help as sort of a point between us and the patient and their family. We, as you guys know, don't want to grab the family and necessarily bring them back immediately. We can park them in a consult area and then have the chaplain kind of go in between, and they're a nice point of care or a point of contact. So the trauma alert red criteria is basically anything that's sicker than kind of what we were just talking about. If their blood pressure systolic is less than 90 at any point, that buys it. That's one that they changed. It formerly was like age greater than 65 and BP less than, I think it was 110. It was pretty high, and the sensitivity was just too high on that. We were getting too many not really sick old people coming back, so they changed it. Gunshot wounds, GCS less than 9 if it's attributed to trauma. Intubated directly from scene, like we talked about. If they have a pulseless extremity, that automatically buys it. Sometimes these are tricky. Sometimes it takes, having that little Doppler, which I don't know if anybody carries around here. There were a few back home that did, but sometimes it can be kind of hard to tell. So that sort of gets everybody down there until we figure out otherwise. If they need an emergent airway, that's going to upgrade them. If they're getting blood, which I guess one or two of our air services now have, if they're getting blood en route, that upgrades them. Any trauma code, that's pretty obvious that you want everybody down there. And then there's discretion. So everybody that you saw on the alerts, plus you get the trauma surgery attending, anesthesia attending, they come downstairs. And really the big thing here, in addition to the trauma team, is that it actually holds an OR open. So upstairs, they get paged about it too. They have an OR sitting there ready, available to come directly up there if that's the case. Usually they'll be able to tell pretty quickly, is this one that we're going to take up directly? Probably not, and they can release it. So people coming from the outside hospital too, this obviously isn't just scenes. If they come and transfer from an outside hospital, even if they're pretty stable, if they trigger one of those criteria, they get the same response as somebody coming from a scene that's undifferentiated. I know sometimes folks come in and are transferring people and will roll their eyes a little bit. It's like, well, this person's a transfer, and it's like, yeah, I know, they look pretty good, but if they have, the pelvic fractures, that kind of thing, as the protocol advised them all of this, and even if they've sort of been through the same song and dance at the outside hospital, the patients get kind of frustrated too, because they've already told probably 10 people by the time they get to us, she already talked about how she, broke her pelvis or whatever. We have to go through the same, A, B, C, D protocol all the way through. And it's, it's best practice. It's kind of annoying for them, and I know probably annoying for you guys too, to kind of come in with sort of a higher stress environment. But they do it for a reason, to make sure that we don't have people fall through the cracks that have other injuries. Because sometimes that happens. We get folks that maybe have things that have been missed. But the outside hospitals wisely are trying to get these people to us as quickly as they can. That's part of the ATLS workup and protocol, is to get these people transferred as soon as you determine that they're going to need a trauma center and you get them stabilized. One thing that I would suggest is, if you have a little bit of time, you're coming from an outside county and you aren't, busy with patient care the entire time, look through that manila envelope. I mean, it's not like a sealed love letter that we're going to like check a wax seal and make sure that nobody's been looking through it. We want you to look through it and see what they said, particularly like scans. If you know what's on the CT scans, because we are always asking, you probably heard us, it's like, asking the nurse, asking you guys, what they scanned? Did they already scan C-spines? What exactly did they do? Because if, they're coming in not wearing a collar, have they already looked into that? Or is it just that, they didn't get one put on? If you know that information, you get like a gold sticker and probably get your name up on the wall somewhere, because that's very, very helpful. This is obviously our trauma bay, kind of photographed from the end that like the helicopters come through. That little area between the two charting areas kind of there on the right is back where the CT scanners are. And this is our setup for those that may not have seen it. I think probably everybody that's listening or watching has. Little carts at the head of each bed contain kind of all of our basic supplies, bandaging, that sort of thing. We've got the big overhead lights just like they have in the OR. And that's not a lot else that probably I can tell you guys that you don't already know. So this is my little beautiful drawing. If you suspend your disbelief and kind of take yourself to imagination land, you can kind of think, this is sort of our trauma bay setup. Down by the bottom of the slide would be where you come in from. Up towards the top would be the head of the bed and kind of that back wall. Highlighting some things, the little guys that are sort of shaded a little bit blue, those are like myself and Walt. One of them would be a resident, one of them would be attending. The guys in white would be one of our nurses, maybe one of our paramedics. The guy in green would be one of our techs. Usually they're kind of up there to be able to sort of hook them up to the monitor and do pressure and everything. The little gray box off to the left is typically where the ultrasound is going to sit. And down in that sort of bottom left corner would be our nurse, who's probably going to be recording things. So you guys come in. Typically it's going to be on the right. Get them transferred over. And that's usually, we try and have lots of room for you guys to come in, although it seems like they always want to have the beds crunched up against the stupid chairs that we don't even need in there, and there's not room for the cots. So always try and kind of slide things over to make sure there's plenty of room. Difference for trauma alert red, you're going to have some extra folks. Oftentimes they'll go ahead and drag a vent in there, especially if it sounds like somebody that's going to be intubated. So that would be kind of that top right corner, is we're going to be where we're going to have our ventilators set up. The guy in gray up there that wasn't there before is one of the respiratory techs. You have sort of a couple of extra people that are a little bit of a darker shade of blue that typically you're going to have a trauma attending kind of down there at the foot of the bed, and one of the trauma residents kind of up there at the side. So our primary survey, ATLS, ABCD, a lot of people tack on F, especially the people that are big fans of ultrasound. So airway, what's your name? And it's one thing that some folks that transfer up to us or transport up to us that don't interact with us a lot, when we ask that question, they'll want to answer it. It's like, I don't really care what their name is. I'm going to forget it as soon as they tell me anyway. I just want to make sure that the patient knows their own name, they're maintaining enough to tell me, and that their airway is intact. You could ask them any other question, you know, how's the weather, something like that. Usually when you ask them their question, ask them what their name is, it's kind of a closed-ended question that doesn't lead to a lot of rambling, because we want to try and run through these things really quickly and get sort of to the meat and taters, if you will. I don't really want to chat with them at that point, which sounds kind of mean, but whatever. Breathing. At the same time as they're telling me that, I can see if they're speaking without distress. If they tell me their first name, have to take a breath, and then tell me their last name, that's a key that maybe we're getting kind of off into the weeds a little bit. And then we're going to listen to their chest, both sides, to be able to see what's going on with those breath sounds. Circulation, you'll see on those alerts, we'll kind of grab both wrists, just check pulses real quick. Usually I'll then move to the feet, and while straps are getting undone, I'll kind of go ahead and look for those pedal pulses. I'll ask them to kind of wiggle their fingers and toes for me and make sure they can feel. And all that can get done usually before we even have them ready to get moved over to the bed. For reds, you'll see the little person that was in kind of the green color up there will be doing a manual blood pressure. And then for the alerts, we do it just basically with the same one on the monitor, the electronic. I don't know, like if we feel like that the manual is more accurate, I'm not sure why we don't do that on everybody as an initial thing, but whatever. Disability or neurologic, we've talked about. Exposure, we'll get all their clothes off. And that's usually going in kind of in tandem with then one of the residents will be doing the FAST exam. For the alerts, it's me. For the trauma alert reds, when the trauma team is down there, they do them themselves. Yeah, that's all I'll say about that. So EMS report. I wish that there was like a 100% answer. I could say, this is when we want it. You know, you're going to do it right after this. And honestly, it kind of varies depending on who's there. And that's something that I'm trying to kind of educate our people too, is they should not have the expectation that you're going to just kind of magically know when to speak up. That's something that we should be telling you guys and say, and that's usually I'll try and say, hey, we'll get them moved over. We'll get that initial set of vitals, and then we'll, run through the report, just to have kind of a standardized way of doing it, even if we can't have a standardized time for it. There's some patients, like if they're shot in the back, or multiple gunshot wounds, those are patients that probably before we even get the vital signs, we're going to be saying, hey, tell me what you know, where they hit, because that's what we want to see, where those holes are before we really do much else. So it's going to vary a little bit from situation to situation, but typically it's going to be after that first set of vital signs is going to be when we want to hear it most of the time. As soon as they hit the door, the clock is ticking. The American College of Surgeons has kind of their recommendations. Typically, it's something that as soon as they arrive, within 10 minutes, we want to have them in the CT scanner or less if we can. That includes getting them moved over. The air crews come in and have like 5 monitors, 20 bags of things, that weird Velcro blanket thing, like getting all that stuff undone. That's all in that 10 minutes. That's getting extra IVs, getting blood hung, whatever we need to do, as well as x-ray. We do x-ray there in the room, that all counts. Typically we get the chest and the pelvis as part of all of these, kind of regardless of what's going on. So clock is ticking. That's why we try and kind of blaze through things, and sometimes it may come across as a little bit rude. So what do we want to hear? There's really, again, not one standardized thing here. There's lots of mnemonics that different folks use. This is just kind of, I think, sort of the meat of things. This was one online I saw that was MIST, M-I-S-T, which is kind of bare bones. Mechanism, T-bone rollover. There's a lot of us that have some EMS background or fire department background, but most people don't. So if you come in and say, you know, this was an impact with significant intrusion, they hit right at the A post, most people probably aren't going to know what in the hell you're talking about. You may have to dumb it down some. Say they hit them right up there on that front fender by the front of the driver's door, and it was all crushed in. Most people can understand that. So you just have to kind of remember who you're talking to. That's something that ideally we would have a better understanding of as a collective group, but we don't. Injuries, that's obviously you're going to kind of give us a rundown of what you've found, where are the holes, where are things sticking out at. Signs to continue that mnemonic, which would be vitals, particularly if they have any hypotension. As we're kind of doing multiple things at once, as you're sort of giving those vitals, unless it's something weird, it's sort of just kind of, okay, that sounds good. Respiratory rate sounds good. You know, sugar if applicable, that sounds good. Particularly highlight if there's anything weird. Say, you know, we had an initial blood pressure that was in the 120s. They dropped down en route. Anything like that are obviously very important. That would be something to kind of highlight. Treatments, interventions, response to them. You can kind of include IV access at that point, I think, which we want to know about, particularly if they're sick, to know sort of what sort of access we need to try and get going. And then medical history and meds. This is not super, super important. I probably don't need to know about their fibromyalgia. I probably don't care. But if they're, you know, a patient that is baseline demented and doesn't know where they're at normally, that would be something to make sure that you tell me. So that way, as we're talking to them more, it's like, well, shoot, Mima doesn't even know where she's at. Well, yeah, she hasn't known since 1996. But if we think that she's altered, then that might, you know, lead to us going down a different path. Meds, really the big thing there would be blood thinners. That's something you want to make sure that you mention 100% of the time. Otherwise, if they're going like, you know, cardiac meds, that kind of thing, it could be helpful to mention. And you can kind of see with sort of the tempo of the room, if things are going, you know, going to shit, you know, you can probably kind of hold off on telling us about all that. But if they're, you know, a significant trauma and their heart rate's been running pretty low and they're on a beta blocker, that would be a good time to go ahead and mention that. That would be something that we would need to know. My suggestion, little red guy down there kind of by the table, I think that's probably the best spot to kind of try and stake out. It's somewhere that we kind of all know where to look. It's somewhere that as we're sort of running around the bed, is kind of out of the way, that you can sort of be in one spot. Back home at Vanderbilt, they actually had like a box taped off on the ground that's like, this is where you stand. And they had a camera that recorded everything, which I think is a little intense. But I think that's something that we could do a better job of kind of having an understanding of, you know, this is the spot where you go. Because that's typically, if we're going to be talking to somebody other than those that are directly around the bed, we're going to be kind of directing our attention back to the nurse that's taking down things to make sure she's getting whatever we're saying. So if you're already back there anyway, perfect. And make sure that you speak loud. That's something sometimes folks, and honestly, a lot of this is sort of like preaching to the choir. I mean, you guys are the ones that are here on your day off, that are, you know, trying to better yourselves. You're the guys that are interested in kind of the cutting edge stuff and doing, you know, the best craft. I'm probably not so much talking to you guys, but you know, some that come in and just kind of want to sort of stand there and quietly tell the nurse what's going on. It's like, no, you gotta speak up. Make sure that we all can hear you. Everybody in the room wants to hear what's going on. So what happens next? Most of these patients are going to get CT scans. We try and target that based on sort of where we suspect that there are injuries, although frankly, a lot of these patients that come in, as you guys know, are so banged up that we kind of end up getting sort of the whole kit and caboodle, which for really anywhere for here would be, you're going to get a head, chest, abdomen, pelvis, and spines. The chest and belly stuff we get with contrast. And if we think they have neck injuries, a lot of times we'll get angiography, or in other words, contrast up through there too. And then the patients that are coming in as trauma alert reds, they're automatically managed by the trauma service for us. The trauma alerts, we manage primarily, the ER docs do, and then consult them as we need to. So next level stuff, I think this is the stuff that, if you're trying to fine tune your craft and be that guy that gets the gold star, 2 large bore IVs, that's something that's taught pretty universally. And oftentimes there's not going to be time. But if that's something that you have a minute to get access on both sides, that's something that can free up the nurses to do other things when the patient rolls in. Something that I think personally is, take off their clothes, which, if you don't have a lot of suspicion for injury kind of under the area that you're looking at, I understand it's a little awkward to kind of cut everything off in the back of the buggy, but for these patients that are going to be alerts or reds, we're going to do it as soon as they get there. We're going to more or less completely undress them. So that's something that can save a lot of time, that sometimes we even have the physicians will be there, hunting down trauma shears to try and cut off clothes to sort of expedite the exam along. If that's something that's already done, that's some next level stuff. That saves a lot of time. If they're transferring while you're at the other hospital, when they hand you the folder, say, hey, there's a disc in there. Probably 96% of the time there is. The times when they don't send us a disc, it just torpedoes everything. If they've done, all of these trauma scans and we're not able to look at the pictures, if we can get them to send them to us, like by a courier, sometimes we'll do that. But a lot of times if they're sick, they just end up getting the whole damn thing again, which A, is quite a bit of radiation, which is not good for the patient. B, it's a significant amount of cost. C, it's tying up more healthcare resources here. It's not the best thing for the patient. So sometimes in the rush to get out the door, those are things that usually they're pretty good about doing checklists and making sure that it's in there. But if you just double check, if you catch one, once a year, once every couple of years that they didn't put the disc in there and you're able to catch that, you're saving thousands of dollars and a lot of headaches. So give them the paperwork. Like we talked before, if you've got time, I understand. A lot of these patients are sick as snot. You're not going to have the time. But if you find yourself sort of sitting there with an extra minute, just look through the packet. Most of it's just kind of nursing notes and things that don't add a lot of value. But if you find those scans, you can make yourself look like a rock star by knowing what they say, and it takes maybe a minute to do. We talked about the imaging reports. Typically, they'll be kind of, you'll be able to tell what they are. They'll say, CT scan of head, whatever, and they'll have an impression at the bottom, which is kind of the money. So summary, give us lots of heads up if you can. We understand there's going to be times when you can't. Be an expert on your patient, even if it's just a transfer. I know, doing EMS back home, it's one of those things that you're sort of always battling the idea that, the ambulance driver type thing. Make yourself an expert on that patient, be a master of your craft, and people, will be less likely to think of you just as an ambulance driver. Talk loud where the whole room can hear it, something that's simple to do. It's intimidating. I mean, even as being kind of the physician, in training the first year, there were many months of doing these alerts where it's like, gosh, what if I say something weird? I'm talking in front of all these people. Just put it out there. Talk loud. Don't be shy. We're all nice. Nobody bites except a couple of the trauma guys. Be concise. And if you can stick around, I know there's times, especially when you're coming from an outside county, that you got to get back. You're the only truck. But if you can stick around even for just a couple of minutes, kind of while we run through that primary survey, usually we end up and have questions. And a lot of times the EMS guys have already kind of jetted, which if you got one person that can kind of get the cot back in service while the other person that took care of them can hang out with us, we'd love that, to be able to, ask a few extra questions. And a lot of times, it's, as you're telling me the mechanism and that sort of thing, I'm trying to do an ultrasound or whatever else at the time and kind of paying the best attention that you can, and you sort of get sort of the overarching idea, okay, this person rolled down a cliff. But a lot of times if the EMS guys are still around, I'll just try and catch up for a minute and say, what did this thing look like? Like, how bad was it? Or if you got pictures, I love to look at pictures. If you got pictures, we can look at those. So if you're able to stick around, I think that's something that's helpful that is not done a lot. You can follow up on these patients, ask us questions. If you see me in the ER the next couple of days, ask me, or if you come back in with another patient, ask me. I'm happy to talk about it. Or you can fill out one of the forms in the EMS report room by the ambulance bay, and we'll get back to you. Just put it in the little box and we'll send you an email. I have to put in a plug for UK Regional Med Control. Well, I think that's the correct phone number for dispatch, yeah. You can call this number, talk to our dispatcher, say I need to talk to a doc, I need orders, and they will patch you through. 24/7, 365. The one caveat is it's one of us, the senior residents, that's carrying the portable phone that if we're in the middle of a code or something like that, then we may not answer. In that case, they'll try and get you plugged in through to one of our other docs, or they might be able to hold on for a minute. And if I see it's dispatch calling, then I try and free myself up kind of with whatever I'm doing. If I'm in the middle of talking to a patient, I see it's dispatch that pops up, politely excuse myself, I'll be back in just a minute. Because in general, when you guys call, it's going to be pretty important. But don't feel bad about, even if it's not that you need orders, if you just want to ask questions. Some of the questions that we've gotten here lately have been excellent. Guys calling in with like some next level stuff that like it takes me a second to kind of think about like gosh, I have this patient that's got a massive head bleed that got bradycardic and I've been pacing them and they're on a narcotropine drip and blah, blah, blah. It's like, gosh, these are some good questions. Don't be out there in the middle of the woods in the back of the bus by yourself. Give us a call. We're happy to talk about it and figure it out together. Even if you're not coming into us, Walt's medical director for a lot of places. We're happy to field those calls, even if you're not coming in to see me. Again, preaching to the choir, you guys are like the top echelon that are here on your day off, or the guys that are, at the stations. Appreciate you guys tuning in. You're the guys that are kind of the next level that probably most of this doesn't really need to be said to, but we really appreciate you guys taking your time to tune in and educate yourselves. Questions?
The criteria, are those UK specific or are those
Yes, sir.
based on national standards?
They are UK specific. A lot of it is pulled from kind of the American College of Surgeons and the ATLS guidelines. And some of that stuff is, obviously fairly concrete. It's not going to change, but those are specific to UK. And that most recent revision was sometime back in the fall that they'd emailed it out. So I don't know when they're going to do it again, but that is specific to UK at this point. So that's some of them back home, like some of the things that I was used to, like if there was a death in the passenger compartment, I was accustomed to that making you a trauma, and that's not included.
It used to be.
Huh?
It used to be.
Yeah. I guess maybe they felt like the sensitivity was too high, although I feel like most of the time when those dudes come in that have been in the car where somebody's died, they're pretty foobarred.
It's still in the CDC trauma triage criteria,
Yeah.
pre-hospital.
And that's, most of those people probably are going to have other injuries that are going to buy them an alert or a red. Me personally, I feel like that makes a lot of sense, but they don't ask me at this point.
See.
Other questions? Cool.